in the Congress.
The case of a 62-year-old gentleman with severe symptomatic aortic stenosis who has an interesting history. 14 years ago, he had the so-called David operation, which basically is surgery for aneurysm of the ascending aorta. That part of the aorta is actually replaced by a graft, and this is a valve-sparing surgery, which means that the native aortic valve is kept and resuspended into the graft. So the past medical history, apart from the David procedure, for which we'll talk a little bit more in a minute, he's also a COPDer, he's an ex-smoker, he uses inhalers once in a while, he's diabetic, and he's developing worsening exertional dyspnea. So we have his echocardiogram, shows severe aortic stenosis with a mean gradient of 41 millimeters of mercury and aortic valve area of less than 1 centimeter square, max velocity of 4.2, good LVEF, and moderate pulmonary hypertension. There are a couple of issues worth noting in this case. He's a relatively young man, he's 62, so he's in the gray zone for surgical versus transcatheter approach. And there is also a graft in his ascending aorta, which makes things a little bit different. Just a a quick reminder about the David operation. Basically, patients who have an aneurysm in the ascending aorta, but the aortic leaflets are intact, are excellent candidates for this operation. The aneurysmal part is excised by the surgeon. Most of the aortic wall is also trimmed down to the sinus of Valsalva, and a key point in this procedure is that the surgeon has to dissect around the aortic wall deep down below actually the level of the annulus. So the graft, which is this one here, will go well below this, the level of the annulus, and the sutures will be placed underneath the cusps, and the root of the graft will be secured in place. Obviously, the coronary arteries will be reimplanted, and inside the graft, the commissures and what's left of the sinus of Valsalva will be sutured to the graft. So we have the graft going well into the LVOT, and the aortic valve, which is sutured inside. And we have to keep this in mind when we're going to choose the correct treatment option for this patient. So this is again our graft, which goes, as we said, below the level of the annulus. We have the reimplanted coronaries, and we have the sinus of Valsalva that you can see them here sutured in place. Now, what happens with these valves? Usually, the patients have a good 10-15 years without anticoagulation, and it's a very good operation for young people because they have low risk of infective endocarditis. They don't have a prosthetic valve, so they don't have high risk of endocarditis. They don't need anticoagulation. But this valve is not hanging in a normal aorta. It's hanging within a graft. So the mechanics are different. And although it's their own valve, over the years it degenerates. It develops either stenosis or insufficiency in equal amounts. And after 10-15 years, a good proportion of these patients will need reoperation for their aortic valve. So our patient had 14 good years. He was working full-time without anticoagulation, but eventually he developed severe aortic stenosis. You can appreciate the graft almost touching inside the LVOT and the stenotic aortic valve. In terms of his coronary anatomy, he has a rather small, chronically occluded right coronary artery. His left system is pretty much okay with a pretty good size circumflex that supplies most of the, sorry for that. Let's go back a little bit. Nothing much to see here, just that the is it something that I do or you guys? Okay. So the question here is, as we said, we have a 62-year-old gentleman. Should we proceed with reduced surgery or should we consider the transcatheter approach? And in connection to the first question, should we go for a bioprosthetic or a mechanical valve? Obviously, if we go for a mechanical valve, we have to choose surgery. Now, we had a lengthy consultation with the patient and the family, and regarding the second question, the decision was for a bioprosthetic valve. He's 62, he has some comorbidities. I think it's reasonable to go for a bioprosthetic valve. So if you're going to put a bioprosthetic valve, are you going to operate? That's going to be a second chest surgery, or are you going to do a TAVR? The decision was finally to proceed with TAVR. The long-term results are not that different in that setting. So if you're going to go with TAVR, what kind of valve are you going to choose? You have the graft, as we discussed, around the annulus. Are you going to use a self-expanding or a balloon expandable valve? There is not much data in the literature, and I don't know if anybody in the room can offer their knowledge on that. There are only a few case reports of TAVR after the David procedure. Mostly the self-expanding valves have been used, and mainly the Medtronic Evolut. Our patient did not have much of calcification of the leaflets. You can see that basically there is a tube there, not much of sinus of Valsalva. The good thing is that the ascending aorta is a little bit dilated. It's almost 40 millimeters in diameter. It's a big annulus, 28, 29 millimeters. You want to have a little bit of enlargement in the ascending aorta because, as you know, the Medtronic valve has some flaring in the outflow, so you don't want that flaring to be compressed. These grafts usually expand a little bit over time. This was a 32 millimeter graft. After 10 to 15 years, you can expect 20 to 30% expansion of the graft. So they easily reach 36, 38 millimeters, as in our case here. So we decided to proceed with a 34 Evolut R valve. The height of the coronaries is decent. I remind you the coronaries have been reimplanted. The left main, I think it's about 12 millimeters, if I recall it correctly. So the deployment was pretty unremarkable. We did do a balloon preparation, very conservative, 23 millimeter balloon, just to get an idea about the behavior of the valve. We wanted to avoid post-dilation because we had a graft there and we didn't want to stretch it too much. And basically after that, we just deployed the valve. We tried to go certainly not shallow, not very deep, but maybe 1 or 2 millimeters deep for a couple of reasons. First of all, we had graft around, so we're feeling pretty confident about that. And number two, he's 62, so probably he was going to need another operation down the line, which might be a TAVR in TAVR, so we want to have the best substrate possible. So we went ahead and we released the valve, and actually we have a pretty decent result, no AI, and in terms of the echo, so sorry that's in slow motion, but everything looked fine. No gradient and no aortic insufficiency. So a few months down the line, the patient is doing fine. He's back to his normal job, and he's pretty happy about it. In conclusion, so TAVR after the David operation is feasible, not just from this one case, but also from some case reports that have been published. There are some potential issues. You don't have much of calcification, usually because these are young patients. So there is a question about possible device mobility and anchoring. What I just mentioned, that if the tube is kind of narrow in the ascending part and you have a self-expanding valve, you might have some narrowing or refolding. That's not usually a problem, but it's something we want to avoid. So we have to be very careful when we're looking at the annulus versus the ascending aorta versus the sinus of Valsalva diameters. Just a reminder, there is no actual sinus of Valsalva, but just the area of the so-called sinus should be carefully studied. Knowledge of the exact details of the Dade operation is crucial, so we have to sit down with the surgeon, look at the surgical reports, see exactly what graft was used, how deep it was stitched, and the like, because there is lots of variations of the David procedure. And again, based on the above, we should choose self-expanding valve, which is usually what has been used so far, although there are a couple of reports for balloon expandable valve in this type of situation. Thank you.
Beautiful case. CT imaging is crucial to see that the diameters, the position of the coronaries, the reimplanted coronaries, and to decide which kind of valve and which size of valve to use. Any comments?
I have a question.
Yes, Dr.
Paulidis, I have a question. This was a beautiful case, and it demands expertise and knowledge of the detailed knowledge of the previous procedure. My question is, commissural alignment is an issue when you have reimplanted coronaries. Commissural alignment of the new valve. Is there an issue with this or not?
We're lucky enough to have the surgeon who performed the initial operation with us, and he had exactly the details of the operation. He made sure that the commissures were aligned in their classic position during the initial operation, during the David operation. Actually, what they do when they put the graft, the first thing they stitch together is the commissures in their normal position. So basically, he explained to us that we should go, as we usually go, for commissural alignment in every case, and that's what we did. And actually, that was confirmed also by the CT data. So we're feeling confident that we won't have much of a problem with coronary access. Although he does not have significant disease on the left side, he is young, so that might be an issue for the future.
On the same issue, I would like to make a comment as well. The case was treated very nicely, and the result is fantastic. Concerning the choice of the valve, for example, I would never go for a balloon expandable valve because you have the previous, let's say,
the graft.
Graft, yeah, sorry. So balloon expandable valve would not be a wise choice. But in terms of self-expandable valve, would you choose, for example, a more coronary-friendly valve like Accurate Neo, because he's a young patient, he has already coronary artery disease, he has an occluded right. You may face in the future some coronary events, and it's true that the Medtronic valve, it's not the most coronary friendly for a new valve, let's say, because he's probably need a new valve in 10-15 years for his coronaries.
Yeah, excellent point. I mean, we thought of all of that, and probably that might be a better choice in terms of coronary access. But again, we're going to have a clean solution. We're going to use a valve that we're feeling comfortable with, and to use a valve that will have long-term data, because all these theoretical advantages for each valve, I mean, if you talk to the companies, every company will have some advantage over the other, but you have to verify that in the clinical setting. And we don't have that yet. So yes, theoretically it may be an advantage, but even in cases where you don't have an optimal expansion of the Medtronic valve within a graft, as I said, there are a couple of cases, they still were able to get into the coronaries quite easily. We wanted to use something that has been used before, because this is a rather unique situation. We were only able to find 2 or 3 case reports in the literature of such cases, so we don't want to have too many unknown variables here.
Yes, but in any case, if you use an Accurate, you have to address pre-degradation. After that, it's the same.
Yes, yes, yes.
Congratulations. Following the same question, would that patient be a candidate for CTO PCI of the RCA?
Well, the RCA is known to be totally occluded for the last 5 years. He was operated upon 14 years ago. It's a rather small RCA. It does give a small PDA. He had some testing and some functional testing in the past, the SPECT, which didn't show much of ischemia. We don't expect that will make any difference in his prognosis. And we are not planning to go into that at this point. He has a pretty large circ which supplies most of the territory. So he's asymptomatic now, feeling fine. So I think for now we'll stay as we are.
Thank you.
Okay, thank you. Thank you.
Thank you.